Ibrutinib is now approved for the frontline therapy of chronic lymphocytic leukemia, regardless of the genetic risk factors that the patient's CLL cells may have. Typically, we consider using ibrutinib for the vast majority of our patients in the frontline setting, except for a small sliver of young patients, and by young I mean patients who are less than 65 years of age, who have standard or low-risk genetic features such as deletion 13q or trisomy 12 by FISH and mutated IGV8 genes in whom we would consider therapy with fludarabine, cyclophosphamide, and rituximab. Several data sets have now suggested that treatment with FCR in this small group of patients can lead to prolonged remissions that can last for 10 to 15 years and potentially lead to a functional cure. In the remainder of the patients, ibrutinib-based therapy has now been shown to be better compared to traditional chemoimmunotherapy in two major trials that were reported at ASH last year, the first one being the ECOG study that randomized patients to FCR versus ibrutinib and rituximab, and the other study was the Alliance study that randomized patients to ibrutinib alone versus ibrutinib and rituximab versus bendamustine and rituximab. In both of these studies, ibrutinib-based regimen demonstrated an improvement in progression-free survival compared to traditional chemotherapy. So I believe that based on these two studies, treatment with ibrutinib-based regimen generally has now become the standard of care for the vast majority of patients who need treatment for CLL. Having heard the results from the Alliance study and the ECOG study at the 2018 ASH meeting, ibrutinib was shown to have a better progression-free survival compared to both FCR and BR. However, one of the problems with ibrutinib therapy is the indefinite nature of this treatment. We've also seen that patients who remain on long-term ibrutinib therapy can develop significant cardiovascular complications such as hypertension, atrial fibrillation, amongst others. This is the reason where venetoclax-based therapy that was presented by Dr. Fisher at the ASCO meeting in 2019, the CLL14 study that compared fixed duration of venetoclax and obinutuzumab to chlorambucil and obinutuzumab, were really interesting data. Here, the treatment cycles consisted of 1 year fixed duration of venetoclax and obinutuzumab, and this led to an unprecedented rates of complete remission and minimal residual disease negative complete remission at the end of 1 year of therapy. This now allows us to consider fixed duration of novel agent therapy that is not chemotherapy based, which is certainly a big improvement in the right direction compared to continuous ibrutinib based therapy. I do believe that there is a role for chemotherapy in the frontline setting for CLL. Again, I think it depends on a number of things. The patient population where I would consider chemotherapy, and I'm specifically referring to fludarabine, cyclophosphamide, and rituximab, would be a young patient, generally less than 65 years of age, who has mutated IGV8 genes and has low-risk FISH profile, and where there is an absence of a TP53 mutation on next-generation sequencing. We've typically now considered using only 3 cycles of FCR based on data from our colleagues at MD Anderson Cancer Center, where if they are MRD negative in the bone marrow after 3 cycles, we do not expose these patients to further cytotoxic chemotherapy because the outcomes and the long-term progression-free survival of these patients seems to be really good. The data for lenalidomide maintenance in chronic lymphocytic leukemia come from studies that were done in the era of chemoimmunotherapy. These patients were all given lenalidomide maintenance after they completed their initial chemoimmunotherapy regimens. These patients typically had high-risk features such as unmutated IGV8 genes or high-risk FISH panel profile. Typically, in 2019 and going forward, we would not use chemoimmunotherapy for this group of patients. And so while the data about lenalidomide maintenance therapy may seem exciting, in routine practice, I do not prescribe lenalidomide maintenance for any of my patients because these patients all get on novel agent therapies to begin with.